Langerhans cell histocytosis. Definition. Langerhans cell histiocytosis is a systemic disease associated with the proliferation and accumulation of Langerhans cells in various tissues. Langerhans cell histiocytosis is a rare disease characterized by the clonal proliferation of pathogenic Langerhans cells and cytokine overproduction. This leads to inflammation and tissue destruction in different organs of the body.
In this pediatric patient who presented with gradual onset proptosis, we see that there is a large mass expanding the inferior aspect of the orbit, with mass effect on the ocular globe. There are additionally similar appearing masses infiltrating the mastoid and tympanic portions of the temporal bones bilaterally. These masses were subsequently proven to represent Langerhans cell histiocytosis at histopathology. LCH is classically subdivided into three forms, namely the unifocal form of eosinophilic granuloma, the multifocal unisystem form of Hans-Schüller-Christian disease, as well as the multifocal multisystem form known as Lederer-Sui disease, which has the worst prognosis. This patient was undergoing further evaluation of the extent of systemic involvement. This condition is of uncertain etiology, representing either neoplasia or a diffuse systemic abnormal reactive inflammatory process. Classic imaging features are geographic lytic lesions of the calvarium with an associated soft tissue mass. A radiographic or nuclear scintigraphic skeletal survey is helpful to assess the extent of osseous disease.
Application in nursing. Having determined the diagnosis of HCL, it is important to conduct a careful clinical study for each individual patient in order to decide the therapeutic approach. Review of the complete medical history that includes the duration of the symptom. Specific symptoms that should be actively so are pain, swelling, rashes, fever, loss of appetite, diarrhea, weight loss, behavior and neurological change. An examination should be performed at each follow-up visit to assess the response to treatment, investigate the possible progression or reactivation of the disease.
About 1% of epidermal cells are known as Langerhans cells. These are a class of dendritic cells, part of the immune system. These Langerhans cells are most common in the stratum spinosum, and they can perform phagocytosis of foreign bodies. Langerhans cells and dendritic cells are important APCs, or antigen-presenting cells. After performing phagocytosis, they can transport portions of, say, the microbe which they ingested to the cell membrane, where they present it to other immune cells and help to stimulate immune reactions.
Pros: Local treatment is usually effective for proximity to an organ. In children, the treatment of systemic force is based on the combination of corticosteroid and vinblastine. Patients with LCH but without risk of an organ involvement have excellent survival and are generally treated with systemic chemotherapy in an attempt to reduce reactivation and prevent permanent sequelae. Cons: Specific treatment depends on the following factors: the classification, the focal or general systematic disease, the dysfunction of the mailing affect organs, and the age factor. As the HCl does not infiltrate the malignant cells, a chemotherapy regimen is not recommended, strong to avoid serious toxins and side effects. It is considerable but HCl relaxes easily and can accompany a malignant tumor. So it is still necessary to carry out long-term monitoring and observation.
So here are multiple MR images demonstrating innumerable tiny T2 bright hyper-enhancing foci throughout the entirety of the liver. Now, could this be some kind of unusual metastatic disease? I suppose so, but it'd be very unusual, right? I don't see a dominant mass anywhere. Could this be some kind of an infection? Could it be peleosis? There's a bunch of things you could think about, and this turned out to be a quite unusual entity. This is perhaps the only case I've ever seen of Langerhans cell histiocytosis involving the liver, with each of these focal tiny hypervascular foci representing a site of involvement.
Issues apply in Ecuador. HCl can occur at any age, but mainly in children aged 1 to 4 years. The incidence of HCl in adults is 1 to 2 cases per million. The majority of patients with HCl are men. Approximately 1 in 200,000 children develop histiocytosis of Langerhans cells each year. LCH can be found in children from birth to adulthood. It is most often found in children 1 to 3 years old. It can appear as a single lesion or it can affect many body systems, such as the skin, bones, limbs, glands, livers, lung, spleen, brain, the pituitary gland, and bone marrow.
Langerhans cell histiocytosis, LCH. The histiocytic diseases in children and adults are caused by an abnormal accumulation of cells of the mononuclear phagocytic system. Only Langerhans cell histiocytosis, LCH, a myeloid-derived dendritic cell disorder, is discussed in detail in this summary. The histiocytic diseases have been reclassified into 5 categories, and LCH is in the L group. 1. LCH results from the clonal proliferation of immunophenotypically and functionally immature, morphologically rounded LCH cells along with eosinophils, macrophages, lymphocytes, and, occasionally, multinucleated giant cells. 2,3. The term LCH cells is used because there are clear morphologic, phenotypic, and gene expression differences between Langerhans cells of the epidermis, LCs, and those in LCH lesions, LCH cells, despite the pathologic histiocyte having the identical immunophenotypic characteristics of normal epidermal LCs, including the presence of Burback granules identified by electron microscopy. LCH cells, known for many years to be caused by a clonal proliferation, have now been shown to likely derive from a myeloid precursor whose proliferation is uniformly associated with activation of the MOP/ERK signaling pathway. 4,5, however, the somatic mutation leading to the activation varies and is unknown in 10% to 20% of cases. 6. In the original breakthrough description of the BRAF V600D mutation occurring in approximately 60% of LCH biopsy specimens, the authors also described activation of the RAS-RAF-MEK-ERK pathway in almost all cases, regardless of stage and organ involvement. 7,8. Since then, activating mutations in several other genes in the pathway have been identified in a significant percentage of BRAF V600D negative LCH specimens, including MAP2K1, in frame deletions plus another leading to upregulation of BRAF, and, less frequently, the CSF1 receptor, RAS, and ARF. 911. In accordance with these findings, the pathologic histiocyte or LCH cell has a gene expression profile closely resembling that of a myeloid dendritic cell. Studies have also demonstrated that the BRAF V600E mutation can be identified in mononuclear cells in peripheral blood and cell-free DNA, usually in patients with disseminated disease. 3,12,13. This shows that multisystem LCH arises from a somatic mutation within a marrow or circulating precursor cell, while localized disease arises from the mutation occurring in a precursor cell at the local site. 3. The above findings have led all clinicians to agree that LCH is a myeloid neoplasm. However, discussion remains about whether it is a malignant neoplasm with varying clinical behavior. The same BRAF V600E mutation has been found in other cancers, including malignant melanoma. However, V600E mutated BRAF is also present in benign nevi, possibly indicating the need for additional mutations to render the cell malignant. 7. Nevertheless, these findings have raised the possibility of targeted therapy with inhibitors already used in the treatment of melanoma. Several trials of BRAF inhibitors are open for adults and children with BRAF V600E mutated tumors, including LCH. Refer to the cytogenetic and genomic studies and cytokine analysis by immunohistochemical staining and gene expression array studies sections of this summary for more information. LCH may involve a single organ, single system LCH, which may be a single site, unifocal, or involve multiple sites, multifocal, or LCH may involve multiple organs, multisystem LCH, which may involve a limited number of organs or be disseminated. Involvement of specific organs such as the liver, spleen, and hematopoietic system separates multisystem LCH into a high-risk group and a low-risk group, where risk indicates the risk of death from disease.
Conclusion: ACL has a high rate for misdiagnosis, and the definite diagnosis depends on the pathological biopsy and the X-ray examination. The prognosis is related to the age of onset and the number of organs affected, although the specific therapeutic approach has not been well established. Combine the chemotherapy for the multisystemic lesion and surgical operation or radiotherapy for unifocal lesion may be improved therapy.
Here is another case in which you see lymphoid-looking tissue. You could see that in about, maybe 10 or 20% of this area, you could see areas which look like clusters of small, more well-differentiated lymphocytes. You can also see that the majority, however, looks like lymphocytes, perhaps not so small, perhaps not so well differentiated, perhaps larger, perhaps more cytoplasm. But most importantly, you see these are all lymphoid cells, and the architecture of the normal lymph node is completely effaced. There's no differentiation of follicles towards the periphery and cords and sinuses in the middle. So that makes this a malignant lymphoma. This one happens to be called a peripheral T-cell lymphoma because they stained these cells with T-cell markers and they were positive rather than B-cell markers. And that's another way of classifying lymphomas. Thank you very much.